So we just have to do our part. And I saw you, Mayor is connecting in. Mayor, are you on the line yet? Well, we'll get him on as soon as possible. But the whole point is that self-control, just the same as our smoking ordinance. It was, we've got people out there to give tickets, but that's not the point. The point is we want people not to be smoking in the parks, and it's up to everybody to help police it. So that's our main goal with all of that.
Thank you.
And I wanted to get back on that question of, well, just on our city update. We're in the phase 2 and we're holding in that location. I pulled this off of the cities, or actually the city's website for zip codes. But just showing you, and these are a week old at least, but just to show you what the growth rate was looking like in our different zip codes. The 7-day growth rate of how things have been increasing. So what I sent you yesterday or Monday that had all the city's Ignite page and the dashboard and the MUSC's dashboard that is keeping track. It's important for us to look at these numbers to figure out where these hot spots are and try to figure out what resources we have in those areas and to try to help address those. So, and then I went on to the website, and this is MUSC's website also. And again, I hope you had a chance to look at those pages, but you know, they've got several where we're in red warnings in area, and talking about where our concerns and our issues are. And I know we've got Brian on from DHEC that's going to speak in a few minutes, but there's so much that we can do locally to try to help this thing. And I think the mayor and city council have gone a long way in trying to put in there the emergency ordinances and preaching about the social distancing and the now the mask requirement. But you can see in the second one, our 7-day average is new 8.3, and prior week it was 5.3 and 3.6. And that's not showing us what's going to happen in the next 7-day average. It's just going to continually to keep going up. So if we don't do something, we are going to be in a little crisis again back in our community. So I really just, I'll let Brian take more from DHEC when we come up on his conversation. But we've got a lot of material out there, hopefully, that can help you in everything that you need to know about what's going on in our city, so that we can work together to try to change this process. But is there any questions? Mayor, are you on the line? I might not have him unmuted yet, so. Anybody got questions or want to chime in there while I'm trying to find the mayor? All right. With nothing, we'll go on and move on to the next one with the Low Country DHEC. Brian, are you on?
Yes, I'm here. Let me just turn on my video.
Brian, maybe introduce yourself.
Okay, sure. Yeah. So my name is Brian Barczyk. I am working with DHEC doing epidemiology in the epidemiology section of the Low Country region and working on data analysis. My day job, when there's not a pandemic threatening everyone at all times, is teaching in the public health program at the College of Charleston, where I teach epidemiology courses and spatial analysis of disease. And so I'm Katie today. She's not able to join the call and asked me to participate, so I'm here to try to bring some data and answer some questions about basically what we see going on right now. And so I'd be happy to either answer questions for what I know or bring those questions up the line back to Katie for her to be able to come back and provide a response, or fill in some data on current situation, depending on what it is that you would like to have additional information about.
All right, Kevin, you want to just open that up to everybody?
Yes, certainly. You know, any comments, any questions?
Oh, I'll say, like, just in terms of what's going on based on the data right now, and one of the things that I work on in the epi data analysis section is to produce a weekly report to look at trends, metrics over the last week or so. And I think everybody can see in the numbers that are getting released publicly and what is announced, for example, in the news, that case counts have been going up quite rapidly recently. I think that there are metrics that are additionally concerning that keep an eye on. One of those, which is publicly available for the state, is the percent of positive tests. And that is the number of people, just as it sounds, who are being tested, who are coming back with a positive test result when it comes to incidents. Not the antibody test where they try to test you and see whether or not you've been exposed, but the one where they do the swab that goes all the way, you know, through your brain practically. That's a joke, but for some people it does feel like they are taking a little piece of their brain with them when they get done with that swab. So for that test, the percent of positive tests, in general, one likes to see those at 5% or below, or heading down, to indicate that as testing ramps up, fewer and fewer people are testing positive for a disease, and that indicates a positive trend in where future incidents or number of new cases is going. And in the last weekly report, which basically ended on Saturday the 27th, because we're looking at this week by week, and there is a daily metric out there, so I don't want to make it sound like there's not. But those numbers are in the upper teens to low 20s, which is clearly concerning, not just for today, but looking forward for a couple weeks, because we know that it takes minimum 2 days, maximum, usually 14 days. Some people actually don't show symptoms or know that they're sick until after 14 days, but it's rare. But that portends that for every case that's being detected, they have the potential to transmit it to, nobody knows the exact R naught right now, but it's somewhere around 2 to 2.5. And so that's concerning looking forward. When that number starts to drop, I think that it's a very positive sign, particularly if that drop is sustained. And right now that drop is fluctuating, like I said, about somewhere between 19 and 20%. And that's one thing that we're keeping an eye on. That is for South Carolina. It's different in location by location. I can tell you that in the Low Country, which is where we mostly focus our efforts, the county that had the greatest increase just in numbers of cases is Charleston County. In the last week, I would say 2 weeks ago, we were looking at about 311 cases during the week of June 7th through June 13th. Last week, 742 cases between June 14th and June 20th. And this week, 1,564 cases between June 21st and June 27th. However, now we know that the mask ordinance has gone into effect. And so I'm hopeful, quite hopeful that going forward, probably not in the next week, it's going to take some time for it to show in the metrics. But 2 weeks, 3 weeks down the line, if we start to see a decreasing growth rate in terms of cases, that will be a very positive indicator for the, in my opinion, effectiveness of the mask ordinance. And I'm very curious to see how things shake out in the next 3 to 4 weeks, let's say.
All right. Anybody?
Hey, Brian, I have a question for you.
Sure.
This is Joey Current with with Trident United Way. So I've been keeping up with the testing and projections site that DHEC puts out where they publish those percent positive rates both in the 14 and 28 day trends, and it's kind of confused me and other folks who have kind of asked for clarification. Because all of the kind of description around that percent positive says if the percent positive is low, then that means that we are testing a lot of people in our state. And if that percent positive is high, it means that we're not testing enough people and that we may only be looking at populations or clusters of groups who have high rates. It doesn't ever mention anywhere in there kind of what percent positive we want to be under, any kind of threshold, what high is. So when the rates are up near the 20%, and I tell people that, they go, well, on the thing it says if it's high, that means we're not testing enough people, so it's okay. And so I'm just curious if there's any language or any clarification that DHEC can put out to help people understand what that percent positive rate is and what numbers we should be concerned about.
I think that is an excellent question. In fact, I will run that up the chain to Katie. I believe that she'll be back next week. I think maybe even having maybe a designator, some threshold of here's where we're trying to get below. Anything above this is what's concerning. I know that a few weeks ago or at other times when the rate was starting to go up, there were questions about, well, is it just that we are having a detection bias? Because we are starting to expand testing and test more people, well, that's why we're seeing more people show up as positive. But it was basically not necessarily increased community spread of disease, but rather simply a artifact of testing more people and therefore detecting more cases. But the sustained trend, I think in my mind and to the people that I discuss with, clearly believe that this is not a testing artifact. There is true community spread, and the percent positive detection is taking place while the number of tests or the testing more people is going up. And there are some goals of testing people in the state per month that are being approached, if not reached. And so pretty soon, I feel like, in my mind, based on what I've seen, the ability to test larger and larger number of people going forward is quickly approaching. So my opinion is that the percent of positive tests really does indicate true increase in community spread of disease, and we're seeing that reflected in the case counts. But there was some question early on about that detection bias, and there still may be questions about that. So I think addressing what do these metrics represent, where would we like to see them to give us a sense that perhaps the epidemic is starting to subside, or any kind of measures such as a mask measure are working to make a positive change to the direction or trend in cases. I think that's a great suggestion, and I will be happy to bring that forward to Katie for consideration and see if there's some work that can be done on that.
Thanks, Brian. And I just had one other question, and then I'll yield for other folks. Recently, on one of DHEC's kind of daily press releases, there was a note at the bottom underneath kind of usual things that people need to do to prevent the spread of disease, which include that list of wearing your mask, washing your hands, social distancing. There was a note that said if you have been around or exposed to someone who you find out has tested positive, that you need to wait 10 days and then go get tested. Is that kind of the official recommendation for folks, is to not run out and immediately run and get tested if you find out that someone that you've been around has come back tested positive? You know, as case rates go up, I think that's going to happen more and more as folks start to venture out and expand that kind of bubble of folks that they've accepted that risk of being around. So I'm just curious if there's guidance, because I've seen a few different recommendations from places, and if you don't know, it's totally fine. But is that kind of, people should kind of wait and see if they develop symptoms first, or what's kind of the recommendation there?
All right, so I just want to make sure that I understand your question correctly. Is that what we're really talking, because if somebody develops symptoms, they're probably going to run out and get tested right away. So what we're really talking about is somebody who's asymptomatic or pre-symptomatic. They have been around somebody who potentially has been confirmed as having a case of COVID. They're not feeling bad today, but they're wondering, should I go out and get tested, or when should I go get tested?
That's right.
The guidance that I've seen more recently says that asymptomatic close contacts should get tested if they can, no sooner than 7 days after the first date of quarantine. So it could be 7 days, 8 days, 9 days, but generally if they haven't had symptoms up to that point, the recommendation is to wait until then, because it's more likely that if they are positive or if they have been infected, they will show up even if they're asymptomatic when they do that incidence test. So I have heard the 7-day wait. I'm not familiar with the 10-day wait, but it sounds like you'd prefer some clarification. And so I'd, again, be happy to take it up to Katie and be like, can you provide the best recommendation here in terms of asymptomatic close contacts and when they should be tested.
Thank you.
Hi there, this is Jan Park, City of Charleston, Employee Wellness, and I can help with that clarification. It is 7 days, and it is in writing from DHEC on one of their health alert networks that came out about 2 weeks ago now. It came out on a Friday, and it does say 7 days for asymptomatic individuals who had positive exposures. And then I just have one quick question for Brian. What is the percentage, if you could remind me, and I know we're far from this, but what is the percentage you look at? Is it percentage or is it case count to show that we are getting towards herd immunity at some point? Because it just kind of seems like at the rate that this is transmitting, we may get to herd immunity before a vaccine even gets here.
That is the $64 trillion question right there in my mind, is where exactly is herd immunity and what would it look like, or what we need to achieve in terms of community, I would say community antibody prevalence to meet that herd immunity. And I think the question is still out as to exactly what that level of herd immunity is. I mean, if we keep having, and I was actually thinking along the similar lines, if we keep having such a huge increase in the metrics of cases over the coming weeks, which I don't think we will, because I do think the mask ordinance will start to make a difference. But there's a couple of variables to that. One variable is how long do people who have had a case of COVID develop immunity? If they do, and for so, how long does that immunity last? And so the parameters of uncertainty on this particular disease and epidemic are still so incredibly wide, it's hard to answer that question. There have been suggestions that people could get immunity once they've been infected and recovered for up to a year. There have been other suggestions that it may be very short term, and we're talking 2 to 3 months. And if that's the case, then people who are getting infected now, people who are getting infected, let's say in the end of March or April, they may be susceptible again and re-enter the pool of susceptibles in the fall, as obviously things change in the city. And so that's a very tough question for me to answer definitively and to give you a threshold value. I will say this, one of the things that we look at is the R naught, which is how many new cases, let's say, are coming from one infected person. And there have been a slew of studies that have looked at non-pharmaceutical interventions, NPIs, like mask wearing, don't touch your face, wash your hands frequently, all these kinds of measures that can be done that do not involve a vaccine. They basically don't involve medical treatment. No vaccine, no treatments. Now, there is a precedent for this working. SARS in 2003, a cousin, you could say, strain of coronavirus, made a lot of people sick, killed hundreds of people. There was never a treatment, there was never a vaccine, but through effective NPIs, that disease was effectively eliminated and then eradicated in 2003 without any medical intervention in terms of treatments and vaccines. And it never came back. In the original strain, it never came back to infect people, even though there was a lot of concern. So I do think there is a precedent for NPIs like mask wearing to actually work, to have an effect. I guess we're going to have to see. I think that we'll probably see a vaccine. I feel strongly that we will see a vaccine or something that works in a moderately efficacious way. Probably, I don't want to prognosticate, but I don't think that we're too far off from starting to see good news in that respect. But we have a long way to go before we get there. And so there are studies looking at these NPIs and what we can do in COVID. And one study says that if we can get 75% of people to wear their masks 75% of the time, we can start to get that R naught to 1 or below 1. In other words, it's going to take time. It's going to be an effort. It requires constant reminding, and communication is the most important aspect. But if there's enough adoption, the measures that are modeled by really, really smart teams of people who are really, really good at this modeling suggest that case count metrics going forward can go down and reduce over time, and potentially tide us over until that vaccine arrives in a way that we don't have constantly spreading or increasing cases of disease. So, there's a long answer to a very brief question, but in a sense, don't have a really good answer. I'm not sure if there's a really good answer out there, but the measures that are being suggested that I've seen and the measures that are now being taken have the potential to be effective and to help reduce increase in incidence of disease until medical treatments and or vaccines can arrive.
Any other questions for Brian? Well, Brian, thank you. Good report.
Carolyn Murray, Kevin.
Okay,
I just wanted to very quickly say, Brian, I had the test, and I think it is important, though I know you said it jokingly, that people not become fearful that the swab is so uncomfortable. I think that might, though it's a small detail, I think that as often as we can encourage people that it takes 10 seconds and it's not that uncomfortable, that people might be more willing to have a test.
all right. Paul?
Brian,
I have a question too for Brian or anybody on the phone. This is Jan Park again with City of Charleston. We're doing all of our internal contact tracing here and, making sure how it's affecting our staffing levels and everything. And my biggest question is, my biggest challenge is educating with employees, making sure they're not getting tested too early if they're asymptomatic, positive exposures, but asymptomatic, not getting them tested too early and all that stuff. But one of my questions is I'm hearing these rapid tests are becoming more popular at some of the urgent care centers. And I have read things that the rapid test, I'm still talking PCR testing, not antibodies, but the rapid test may not be as accurate. If anybody on the phone call has that, because obviously people are tempted to get those rapid results. And as an employer, it would be awesome because we're keeping people out of work for days waiting on results. So if you have any information on whether rapid testing, getting those results in 15 to 30 minutes is accurate or not, that would be great.
Hey, this is Meredith from Rubber St. Francis. We've had those rapid tests are in the hospital. We have tests coming in every day, trying to keep up with demand, and we're seeing really good results actually from those tests. And we it's kind of I think when you're talking about employees, it's a catch-22 when it comes to that, because you're going to have someone that's exposed or could be exposed, and they have the test, and let's say you're going to wait 5 days versus 5 hours. Even if that test comes back negative and they're symptomatic, you're going to be hesitant on letting them come back in the workplace because of a possible false negative. So
Well, we're not sending them too early. We're still waiting the appropriate time to send them. But once they get tested, we have employees that are waiting days to get their results back.
Right. We have the fast action, the test here. We can get it done very quickly, and we adopted that really because of our inpatient base as well, but for the number of patients going through our system. But we have there's a CDC guideline that we've kind of worked with first contact, second contact, third contact. So it depends on where you were in proximity to that COVID-19. So the second and third contact, you may not want to, like you said, wait to see when they get tested. We've had some patients come in. We do really heavy on the virtual care. So if you're showing symptoms and we're near someone, then yeah, we'll go ahead and get you tested. But a lot of times, if you're not showing symptoms, we'll just ask you to self-quarantine for a couple of days. And but like you said, waiting 4 or 5 days to get a result back and not being symptomatic, we're pushing on the end of side, letting everybody work from home, trying to do the best you can with that. But it's really hard to judge when it comes to that. How safe do you want to be by letting them come back to work, possibly being asymptomatic, but possibly carrying the virus as well. So it is extremely complicated, but CDC guidelines showing that if you are directly exposed to someone with COVID-19, you need to do self-quarantine and start looking for and start I guess, heading in that direction to get tested. But second and third, they're not recommending tested. So if you know of a friend, that type of thing. Does that make sense?
Yeah, it does, and I appreciate the answer. The challenge, though, is when you're a municipality, we have critical infrastructure, essential workers like police, fire, garbage,
Right.
and we have to provide those services. And I know there is language under there where we can allow them to work once we get to critical staffing, but I just want to challenge all of the providers on this call to maybe get a little bit more organized in telling us if those rapid tests are actually accurate, and get some data on the results if they're accurate, and is there going to be any kind of prioritizing first responders, critical infrastructure workers, when it comes to, we have to get them back to work. We cannot sustain the trajectory we are on of having this many people out of work, waiting 4 days for results. Now, if they're symptomatic, we're sending them home.
Right.
But I'm talking people who feel perfectly fine to work, but they may have had an exposure, or even if we know they had an exposure, we're just trying to figure out if they're positive or not. And we do allow people to work from home whenever possible, but there are a lot of workers out there that have to run the city who cannot do their job from home. Police, fire, garbage. And so they're getting mixed in with all the other people going to get tested. MUSC does have a priority for first responders, but there's so many first responders going that even got a little backed up. But I just think that there's a lack of information out there on these rapid tests, because I'm hesitant to send my guys out there unless I know they're accurate. So anyway, I'll stop there. But these
For the
critical
group,
infrastructure workers really do need to have a clear path on how we get them back to work quickest.
Following this meeting today, I can speak with our director of the laboratory, and I can get those results for you. I can send them to Paul, and we can send them out if you want to do that, for what we've experienced.
Okay, super. Thank you so much.
Sure.
Very good. Thank you, Meredith and Jan. Appreciate that. Any other questions for Brian?
I just want to second what Carolyn was saying. I think messaging and communication is it cannot be considered ancillary to any measures that are being taken. It's so important to have effective communication and make sure that the recommendations are understood. So I just want to re-emphasize that point. I know over at the college, we are having discussions about how do we make sure that the messaging gets out about how important it is to take the precautions that are being recommended, because if they're not followed, the end result is that one test might not get conducted and people might not know, and they have the ability to spread the disease to others, or they don't adopt precautionary measures which could protect not just themselves or their families, but the entire community in a sense. We all have a role to play in this. I think getting that messaging out and consistently getting that messaging out is part of the entire process of responding to this epidemic. Okay, thank you. Thank you very much for your time.
Appreciate it. Carolyn, I did get an answer to your question earlier that right now our livability department is educating and warning at this time. They've not yet written a ticket, so just to verify that with you.
Thank you, Kevin.
Yes, ma'am. All right, so we're going to move on to our city health dashboard, and I'll bring that over to Paul then.
Thank you. The city health dashboard, just for clarity, and I will make sure everybody knows about the mobile clinics that are in our community. I'll send that out to you, but I wanted to touch on that before we left the DHEC site. Between Federal Healthcare and Charleston County, we've got some clinics that are out there, and then the hospitals and the CVSs are also doing them. So I need to get that out to y'all as much as possible so you can help publicize that to where we are.
Paul, I have to interrupt you real quick just to say that the clinic that you have on there at Trident United Way has actually been moved to Trident Technical College.
Okay.
They wanted a bigger space, and it's just like a quarter mile down the road. And so just so that when you send that out, it's going out to Trident Tech instead on July 1st, today.
Okay. Good. Is that corrected on the DHEC site?
It should be. It should be. We've been in communication with DHEC the whole way.
Okay. Well, I'll follow up on that and make my correction, make sure our city's page is corrected too. And then, so the City Health Dashboard, I want to just take a few minutes because we've been talking about this over the last couple of meetings. And Mayor Tecklenburg had challenged us to really look hard at where the health, the life expectancies were. And this is just another tool for us to look at. And we know DHEC is working on it. This sort of helps break it down into smaller components. The city dashboard was a product out of New York University School of Medicine Public Health Group, and it was funded by the Robert Woods Johnson Foundation. They focused their information on, I still got 37 here, but it's 35 measures of health, the factors that shape health and the drivers of health equity to guide local solutions for our U.S. cities. And their mission sits there to equip cities with a one-stop shop resource for comprehensive, reliable data to help them build healthier and equitable communities. What you'll find as you're looking for it, it allows us, our cities and our staff and community leaders to compare health group access that are in neighborhoods. Now they're breaking it down into census tract where you can even get a little bit more detail. We can compare cities to other cities that are in our same region or similar population. And it should help us as we're going forward, looking at the different health priorities in our community to begin to set some priorities and by better targeting the resources that we have around to us. So I wanted to just call your attention to that to look at it. When you look at the city dashboard, they break up their measures into several different areas: health outcomes, clinical care, physical environment, health behaviors, social and economic factors. And then they will go down into those, and I'm going to zip over. I'm going to probably not do this very well, but I'm going to try to come out of here and go to another page real quick. And just show you a little bit of the dashboard. Sorry for that.
I've also got it pulled up, Paul, if you want me to share it as well.
Are y'all? Nope, I pulled up. Do you have it, Joey?
Yep, but you got it pulled up here.
That's up.
Okay. Okay. So you can see on the which one do y'all have the one that says health outcomes?
Yes.
Right.
So if you see the different health outcomes on here, they'll show our whole city and go through all the different the schedules of different things that they're measuring. It even will go down and show the demographics of our community. I'm sorry, I'm having a hard time moving my disc. It comes down, if it's going to cooperate with me, and will show even the makeup of our community from all the different ages and race and gender and all. So those are important things for us to know and to be able to have. And again, this is a good tool for us to look at as we're going forward. I did want to go into, because the mayor had said many times that we had been talking about this, and I wanted to, you ever have trouble where your mouse just doesn't work?
Yes.
Anyways, if I can get back to that page, if I click on life expectancy and come over to the arrow and click on it, come down, I'll pull up a map, and in that map we can enlarge it. And I thought it was interesting. I was playing with this today. but you can go over and you can take a neighborhood in your community and just look at the different life expectancies of where in our city the life expectancies change. And these are more by census tracts of where they are in our community from. And you can see the city's outlines are in the colored ones. That if there's some white spaces in there, that's either San Andreas Public Service District or the non-areas within the city. But you can look at just life expectancy in those communities, and that just helps you to understand where we have issues that are sitting out there that we really need to pay attention to. And then we can go back to our website and look at all these other items that are here that look at the health outcomes, that we could look at what's in those neighborhoods specifically with diabetes and everything else. But I wanted to today is just to really get you to focus on knowing this is a tool out there. And as we go through our planning and looking at things in the coming weeks and months and years, this is a great asset for us to have from city planners to community leaders to in your area, if it's your faith-based community of where your members are coming from, and trying to understand maybe some of the issues that are out there that we're not hearing enough about, but things we could do more to try to bring into focus. So that was our point today, is really just show this off so that you could have an opportunity to drill down on your own and look at what's around your community. And I'll leave it at that. It was more for just getting you familiar with it again.
Paul, can I add one thing real quick?
Sure.
I'm going to put the link to this dashboard in the chat so that you guys can click it, bookmark it, refer to it, because I'm sure there are specific areas of health or health outcomes that different folks around the table are going to be more or less interested in. A few things I want to mention about this tool. First off, you're going to see there are metrics across the board, and the icons that they use are a kind of sliding scale of blue. A dark blue dark blue census tract or a dark blue zip code is going to have worse health outcomes than a light blue or a lighter colored area. I also want you guys to see that on each of these outcomes, there's a little triangle at the bottom of that icon, a little dark blue triangle. That dark blue triangle shows the average outcomes for the cities that this city dashboard looks at. So there's 50 other cities across the United States that they look at, and they take the average of that. So the yellow bar shows us where the city of Charleston is in comparison to those other groups. And if there's a green check mark over that yellow bar, it means we're doing better than the average cities that they've looked at. Now that can be a little bit misleading, because if we look at things like life expectancy and some of these other outcomes, we can see we're doing much better overall. But if you actually drill down, and Paul, if you'll go to that map again view that you had, where you could click on each of the census tracts or the different zip codes. So Paul, if you scroll down and click on one of those dark blue areas for me. So you'll notice that when you click on one of those dark blue areas, go ahead and click on it. Don't just zoom in on it, just click on it real quick for me. There we go. There you go. So you'll notice on the page that zip code that we clicked on popped up. It went away when, I think for a second, I think Paul clicked away, but click on that dark blue area again. Okay. You're just zooming in further. It's okay. What you can do is you can look at that specific census tract compared to the rest of the city of Charleston. You'll notice that there are many of our census tracts and zip codes that are doing much worse than the average. And you can even pull up a nice little graph of all, you're just zooming in further and further there, Paul. It's okay. It's all right. I encourage you guys to play with it. But when you click on one of those dark blue areas where they're having worse health outcomes, you'll notice that you can look at them now compared to everyone else. And you'll see that Paul has two charts pulled up. And there you go. And that chart is now down at the bottom, depending on what health outcome we're looking at, shows you how many zip codes we have that are in that dark blue range versus that light range. So you can see for this particular metric we're looking at, there are 3 zip codes that are doing very bad, very poorly for this metric. And then there are a few others that are in that upper end of the scale. So I would encourage folks, if you're doing any kind of targeted outreach, any kind of targeted messaging or intervention work, to consider that even though on a whole, a certain health outcome may look like we're doing okay or better than average, that there are going to be certain zip codes and places within our city that that are not doing that as well. And we can focus our efforts on those areas. And the last thing I'll mention is since Paul's got it pulled up, is that this group out of NYU has done some work to put together a COVID risk index. So as opposed to kind of your normal health outcomes and even social vulnerability, which folks may know kind of takes into account an amalgamation of kind of your socioeconomic status, your housing and transportation issues. They've also added in some indicators that we know put people at higher risk for COVID, such as chronic disease, like obesity, diabetes, heart disease, as well as some of the groups and minorities and age groups that we know are most affected by COVID. And they've actually charted out those areas of our city which have populations that are going to be most at risk. And they line up fairly closely with those communities that have the largest disparity in life expectancy. But I encourage folks to kind of use that as a tool. United Way has used this tool and others to kind of target our food access work in light of COVID in our food response, where we've partnered with certain communities to do food distribution and outreach. And as things move on and we see that the basic needs of folks in light of this pandemic shift from food to utilities to other basic needs, we're going to be using tools like this to help us identify kind of hotspots and areas where folks are most at risk that we can work in. So I just wanted to share that with folks so you're aware that this tool exists. It's very helpful for groups like United Way, and I think for this committee as well as we think about education, advocacy, and awareness.
Thank you, Joey. Thank you, Paul. Appreciate that. It's a great website. I think this can help city council members and other leaders in the city as well. So thank you for that and your explanation. Great tool. So we're going to move on to Paul, unless you have something else, I'm going to move on to the city and community health updates. Do you have anything else on there, Paul, before I move forward?
No, I think that's all we had.
Okay. All right. So we'll move on to city and community health updates. Not to put Maggie on the spot, but if she wanted to update us on the schools, this probably would be a good time if you'd like, Maggie Dangerfield.
Sure, no problem at all. I apologize. Bear with me one second. So we have a reactivation task force, which has been meeting. They've had 2 meetings. I believe the first was June 6th. The second one was June 26th, so last Friday, as well as in addition to the task force, we've had the deployment of a second round of surveys to our parents last week, as well as teacher listening sessions. So all of which in an effort to gather voice and input to help inform our decision making going forward. Essentially with the task force, it is looking at all aspects of operations from logistical to business practices to general to continuity of education. Right now there are 3 models that the district is considering. Of course, the first would be what we call our default or traditional, which would be our typical daily face-to-face instruction for students. The second would be a hybrid, which would be a blend of face-to-face and distance, but not necessarily distance in the aspect of virtual. It may be an A day at school, a B day at home doing homework. So looking through the possibilities of that and what that looks like, and if that would be applied across the board or just in facilities in schools where we just can't handle the capacity of students that are enrolled in order to practice safe social and physical distancing and other resources there. And then the third being our full distance learning model. So complete virtual instruction, which would be different than a new effort that we have developed, which is our Ccsd Virtual Academy. So that's a full online academy that the district itself is creating and sponsoring that would have its own set of instructors, and students would register to be a part of that for the year. So they wouldn't float in and out of in-person or per se distance at home learning. They would just be fully enrolled in virtual, but because it's with the district versus like sponsored by the state like SC Online is, we're able to retain funding of those pupils that would be enrolled in that program. And we just started opening teacher application spots for that last week. And of course, we're using our survey data and other means to gather what a baseline amount of students would be in terms of their interest right now in enrolling in that kind of academy. Our reactivation task force meets again next week on the 10th. And we'll look through where we are with the latest data. We have individuals from DHEC and MUSC that serve on that. And so we are, of course, following the guidance of our local health leaders on what to do and what scenarios may be best. And certainly within all of this, there's been logistical considerations with, like, for instance, the ordering of plexiglass partitions that are kind of like an X formation that would allow, like in an elementary setting, 4 desks to be in a cluster with that separation clustered at intervals of 6 feet apart in order to serve roughly 20 to 24 students in a classroom in a high school setting. It would be the typical high school desk, the adjoined desk part to the chair that would be, like a row on the back, 6 feet, another row, 6 feet, another row, which would allow us to serve about 16 to 17 students in a typical sized classroom at the high school level. As well as considerations about cutting off water fountains and providing use of personal water bottles, in-service meals in the classroom versus going into a cafeteria area, and of course, the logistical considerations of buses and how to handle capacity there, whether it be A-Day, B-Day for that, or staggering of scheduling, but also trying to determine what is best and following guidance there, since we cannot install a plexiglass partition between a driver and a student, so we already lose 2 rows of distance needed between the driver and the first row of children. So all of that is being carefully considered and developed every day at this point. We have a copy of the Reactivation Task Force meeting via video. I apologize. Go right there for a second, baby. We have a copy of the Reactivation Task Force video that is posted on CCSD's YouTube site. It's also linked to our homepage that has a similar PowerPoint into it that kind of dives deep into all of the particular considerations that we are going through, as well as the superintendent's report from our Board of Trustees meeting last Wednesday, June 24th, that is also available on our website that outlines that as well. So that's just kind of where we're at. Constantly changing every day, but still really focusing on gathering input and voice and trying to gauge what families and parents would want, which would, of course, inform where we're going in terms of staff preparation, bus utilization, so that particularly that parent survey that went out last week asked questions about that, and that'll be redeployed again the week of July 20th, because as we know, things change from week to week. So someone's preference and choice a week ago may be different a month from now.
Thank you, Maggie. Any questions for Maggie at this point?
Kevin, could you call on the mayor real quick?
Sure, Mayor Tecklenburg.
Well, thank you, Councilmember Shealy, and thanks to all of you serving on our Health and Wellness Committee here. I know I was a little late coming and I got to zoom off in a minute, But I know we're all concerned about the numbers we've been seeing in Charleston County. I'm saddened by it really, and a little alarmed. We've now for 9 days in a row, I think, had the state's highest numbers in Charleston County, and that's very disconcerting. I want to thank City Council for supporting our mask ordinance, which, as you all know, is effective today. And although we want folks to have a nice July 4th, please help me, just everyone, put the word out about wearing a mask going forward. It's one of the few tools we have available to us. I'll be doing my best in the media to continue to promote this. It's the one thing we've got to talk about this weekend. So thank you all for your service, and please help us continue to get the word out about wearing your mask and just being safe. God bless you all. Thanks.
Thank you, Mr. Mayor. Appreciate that. Dan, did you have something, Dan? You're on mute, Dan.
Yep. So just thank you, Mr. Mayor, for your leadership. And again, just to echo the thoughts from City Council, really appreciate the focus on helping individuals take some measures. And forgive me, I've not been really tracking other discussions about things we could do from a policy perspective locally. So I'm just going to ask the question and apologize for the naivete of the question in advance. Has there been consideration, or is there an appetite, forgive the pun, for shutting down of some businesses? I guess I'm thinking mostly about bars and areas where there are large gatherings of people in very tight spaces, and considering that at the local level. I know there's not an appetite for it at the state level, but just wondered what the conversations are around that at the local level.
Right. Well, you're right. There's not been an appetite for that, and some of the actions that were taken at a state level kind of almost mandated that changes to what we had done previously on a municipal level. I will tell you, I want to get through this weekend and just focus on the mask right now. I think to add something, in the next few days would be kind of confusing. I want to just focus on this. The next thing I'm going to ask City Council to consider, if our healthcare professionals agree that it's not to close anybody down, but look once again at occupancy limits and limiting occupancy limits, particularly in bars. The places, my understanding is the places where people gather and congregate, particularly indoors, is where we have the highest risk of, contagion. And so that is something we would consider again.
All right. Thank you. And Carolyn? Carolyn, you're on mute. Carolyn, you're
still on mute, Carolyn.
Carolyn, you're muted. There you go.
Oh, you were, and then you weren't. Now we got you.
Okay, I'm so used to a microphone, so pardon me. I just wanted to emphasize what the mayor was saying, talking about occupancy limits. But of course, one thing that comes to mind is this weekend being a weekend when a lot of people will be together. How will we go about messaging that to the community, the importance of wearing masks when people will be congregating this weekend, and especially since there will also be family reunions, of course, the 4th of July, and some graduations that are still taking place?
Well, my plan tomorrow is just to focus on the unfortunate numbers from the last 10 days of what we've seen in Charleston County. And I'm not saying it's a scare tactic, it's just reality. If you look at the numbers we've been experiencing, and I'll have some graphs and charts available to share, Carolyn, with the media tomorrow. I mean, if you look at the numbers, and it's a scary picture. And I think we just need to be real with our citizens and share these numbers and try to elevate the concern and ask people to do the right thing. We'll get some numbers to you.
Thank you.
Yes, ma'am.
All right.
All right. Good to see y'all. Thank you so much.
Thank you, Mr. Mayor.
Thank you,
Appreciate
Mayor.
you being on. Thank you. Okay, so continuing with our community health updates, Paul, do you have anything here? Paul, you're on mute right now.
We always run out of time, but there's too many good points that still need to be brought up. And I wanted to make sure, Susan Johnson had brought up a question over, are we looking at open roads in our community? And I know Jennifer's got some good comments on mental health. And so I hope we can take a few extra minutes and just cover those items and remind people on our committee that the city has a great resource on COVID-19 for them to put material on so we can help get it into our community as well as what you're doing. So please send that to me if you've got stuff that I can put out there to let people know about the resources in our community. So I did want to take a few extra minutes that maybe we could just try to address Susan's question and get Jennifer to jump in there as well too, and anybody else that has any. And I think we skipped over Maggie's question. From Maggie, I think July 10th is the school district supposed to make a recommendation?
Yes, so the hope is to have some recommendations there. I think our absolute deadline is July 24th. However, I know we have a July 20 committee of the whole and joint board of trustees meeting. So I do believe we would strive to have something more definitive determined by then. Currently, I did not mention this before, but currently our calendar remains the same. August 18 is our start date for K-8 and at the time 9 through 12 students. We do have 5 extra days for K-8 students that have been funded by the state that have to be used before the end of the calendar year. When and where and how those will be used is still being determined based on input and needs being gathered, but we know at this time they won't be used ahead of our original start date, which was being considered initially by the board pushing back to August 11th. But with the case and the rate of transmissions right now, that original start date remains the same. And should it change, our board would probably call a special called meeting to make any modifications there. Additionally, our offices currently are still in their, they're going to assume their current posture of remote working with intermittent staff going in as an on-need basis until at least August 1st. And so next Friday, we should have some more ideas and processes fleshed out. Of course, something I didn't mention either is the consideration of PPE. So what are going to be our protocols? What are we going to ask staff and students to do? Who's going to provide that? Lots of things have been discussed, you know, kind of similar to what our current protocols are when you enter the office, you know, a mask from your car to your personal space, then you can remove it. And then if you leave your personal workspace, you put it back on, whether it's walking to the copier, the restroom, or to speak to another colleague in their doorway. So same considerations going on at the school level about what that would look like. But all of that, again, is kind of outlined in pretty good detail in those PowerPoints I referenced. So hopefully more to come with some definitives. We said that we would give parents at least 20 days notice before the start of school as to what we are striving to do. So
I guess with the city's ordinances for mask, how does that affect, because North Charleston maybe is a city that hasn't done it, but the rest of the cities have mandated in public places. So does that affect schools, Kevin? Is that, or Mike, does that affect schools?
I would imagine, yeah, it's a you know, it's a public space, so I would imagine, you know, that those that applies.
Just another one for y'all to add to your list.
absolutely. Yeah, and we definitely are aware of that and are taking that into consideration as well, about how that would play out, especially if those are extended long-term beyond their current ordinance dates.
Can I ask Maggie a quick question?
Absolutely.
Thanks for the update and thanks for all that
Sure.
schools are trying to do to think through all this. And my question was about that potential option for an online academy.
Mm-hmm.
What thought there's been to class size or section size of a given class? I could imagine, I'm not sure, but I could imagine it being potentially a very attractive option for parents, but also wondered about what thoughts there have been around how big a class might be.
Sure, absolutely. That's a great question. I don't have an answer at the moment because I think we are still in that initial phase of gathering how many students would truly be interested, which would then tell us what class size may need to look like. If it was only like 5% of students, that's vastly different than 15 to 20% of our current students. So that data is being gathered, and we're going to onboard enough teachers to serve at a smaller capacity initially, and then once we see what the enrollment really looks like, continue to add certified staff from there. So as soon as we have some more definitives there, I can certainly circle back with an update on what that class size would look like. But I wouldn't imagine we would want it to exceed anything that we would do in person in terms of class size.
All right, thank you, Maggie. Maggie, a couple of weeks ago, athletes were asked to be tested for Charleston County schools, high school athletes. Do you know if we have any data on what percentage actually got those tests, and then any other data beyond that on positive negatives?
Sure. I'm not certain. I can ask Ellen Nitz or anyone that may be privy to that. I don't know with HIPAA and other regulations what we would be disclosed, or even if we would know. Since I know that some of the mobile testing sites were set up at our CCSD facilities, but I don't know if necessarily everyone that came identified themselves and what organization they were tied to. But yesterday we announced that we are postponing all summer workouts through July 20th, which also mirrors our postponement of in-person summer semester to July 20th as well, due to current transmission rates. I do believe a component of our summer semester, our online learning, will still commence next week, but the in-person pieces, as well as athletics, are postponed until then. But Councilman Shealy, I'll inquire about that and see what I can figure out.
All right, thank you. Paul, who did you have? Did you have anybody up next?
I didn't know whether Susan, I know, had talked to me about a couple items. So I wanted to make sure we gave her an opportunity. And then I just want to hear from Jennifer, because I know she's got to talk to us about mental health in this picture. Okay. Susan, are you out there?
Yes, I am. Can y'all hear me?
Yes.
Yes.
Okay, great. Thank you so much. I just wanted to, and some of you may already be familiar, but the City Bike and Pedestrian Committee is putting forth a pilot program to open streets, and they are hoping for this committee support. It basically, there are a couple different components, but it really is opening up either existing parking spots or streets that are currently vehicular traffic to pedestrians, and allowing businesses to expand their services out into those areas. And the short-term goal is to provide a safer environment for businesses to continue their operations. And I have the materials from Charleston Moves and from the committee that are, we basically maybe could decide as a committee to provide a letter of support as that goes to City Council on July 14th. I'm sorry I didn't have this information in advance of this meeting, but Paul can certainly send it out to the group, and maybe we can make a decision via email because that meeting will be held in 2 weeks, and I think it's certainly aligned with our goals of this committee, short term in relation to COVID, but then longer term certainly around bike and pedestrian, the promotion of safe bike and pedestrian opportunities in Charleston.
Mike had a.
Mr. Chairman,
Councilman Seekings?
Thank you. Susan, thanks. It's Mike. Mr. Chairman, thank you. And Paul, as you may or may not know, I'm the chairman of the Bike Ped Committee, and City Council through the TNT Committee charged us with looking at open streets and coming up with some definitive projects that we could recommend back to council that could be implemented short term, then with the long term look at other options that may be out there to support, among other things, business and mobility together. We are ready to make our report after not one, not two, but three, about 3-hour meetings that we've had since in the last month. And the two things that are going to be recommended back to City Council, and I guess you all are hearing this for the first time, breaking news, is to shut down the south side of Market Street to traffic and open it up to walking, commerce, and all the like between 10 in the morning and 4 or 5 in the afternoon, between State Street and Church Street. So it's a pretty small stretch of it, but it's actually a pretty big step. As you all may know, we are in the process of phase 3 of the underground drainage project of the market. So this would be in connection with that. The other recommendation is to take a stretch of Wentworth Street on the peninsula between King and Meeting Street, which is currently one way from east to west, and take the southern lane and turn it into a two-way cyclotrack, so to allow for two-way bike pedestrian access across the entire peninsula, which currently from east to west there isn't. We have also charged our Civic Design Center and to look at some ways to expand outdoor dining and outdoor retail sales without closing down major commerce streets, and in particular King Street. One of the things that was talked about was shutting down King Street. That was not accepted by the committee as an option for now, but using some portions perhaps of the resources along King Street for dining and other retail opportunities. We also looked at West Ashley, and we're going to take that up next meeting. There's some opportunities there for open streets, taking away or coexisting with bikes and cars in the Magnolia Avenue corridor. Kevin will talk about that, but we haven't gotten that far. So we've done a lot of work. We're slowly but surely getting there, and we'll be reporting back to City Council, like I said, next week. So any support this committee can give just generally for the work of that committee, I think would be great. It's going to be hard to keep you updated in real time as to what we're doing because it changes almost hourly. So that's the report from the chairman. Thank you, Susan, for bringing it up, and we will keep you up to date as we move forward.
All right, thank you. Anything?
Mike, I'm sorry. Mike, this is Susan. Thank you so much. I was hoping you were on. And would it be helpful for this committee to submit a letter of support? And if so, I do have a draft of that I could push out through Paul.
Yeah, definitely. The good news is that City Council did charge the Bike Ped Committee with doing this, so it's on Council's mind. It will be up for much debate, I think. So any support that can come from this committee would be greatly appreciated, and I think very, very helpful.
Okay, great. Paul, I'll get you that this morning.
Ironically, it's going to come before Traffic and Transportation, which I'm also the chairman of. So anything you can get to me would be great. And Councilmember Shealy, I'm hoping we'll get his support. We'll talk to him about it. But I think there's an appetite right now, not just on City Council, but in this community and communities at large to look at open streets. So this is a really great time to do it. Really great time. So let's get moving, and we'll start small and grow from there.
All right,
Awesome. Thank you, Mike.
Just a real quick point. I want to make sure everybody understands exactly what an open street is.
Well, there's a couple of different definitions of an open street. One is a closed street that allows other things other than cars. But open streets are basically mixed use in the street in the public right of way. You may have seen some examples around the country. If any of you have ever been to Park City, is a really great example. On the main street in Park City during the summertime, they actually put little parklets and eating areas into the main street. Open streets is just a whole concept of using streets for things other than just cars and parking. we've sort of expanded that definition at Bike Ped into looking at streets in general and doing some things that are different than traditionally composed when it comes to streets, which is just cars, and sort of putting bike and ped to the side, maybe looking at Bike Ped and other business opportunities as the principal objective, with cars secondary. So we've expanded it and kind of turned it into more of a hybrid on our committee.
Thank you.
Anything else under city or community health updates, Paul?
Jennifer, do you want to touch on anything?
Sure, I'll just be really quick. Yeah, we're still here and we're still open and accepting walk-in appointments. We're mostly seeing telehealth visits as much as possible, but we are seeing patients face-to-face. But just a reminder that DMH did get a grant called South Carolina Hopes, and it can help pay for underinsured or uninsured folks who need mental health treatment as a result of COVID, where they've had either increased symptoms from because of COVID or new symptoms. They would come through the same way they always do with us, but we can help pay for medications for people coming out of jail with that grant, and also help people get drug and alcohol treatment. Just a reminder to everybody too, we have lots of trainers for mental health first aid, which is an 8-hour course for teaching how to recognize signs and symptoms of mental illness for adults and for kids. We have 4 trainers in our center. We provide the course for free. So any agencies, businesses, anyone interested, just give me a ring. And I guess one last quick thing is kind of exciting, and we should be hopefully rolling this out soon, but we've had to expand our mobile crisis team. That part isn't good because we're so busy. We are getting more and more calls, and this weekend I expect it to be really busy also. But we will be rolling out our person that's going to be in 911 consolidated dispatch in Charleston. So we're going to have a mental health therapist there who will be taking calls passed to us, certain types of calls that 911 is getting. And the ultimate goal is to reduce the number of resources that get sent out for mental health calls. Maybe we don't have to send fire, police, and everybody else. Maybe we can just send mobile crisis out there. So we've been virtually training with them, and now we're just kind of getting some training together for fire, police, and everybody else, so they understand what we're going to be doing and how we're going to be working with first responders out of 911 dispatch center. So that's kind of exciting, but yeah, we're still here. Call us if you need us.
All right, thank
I know we're late, and I did want to jump on and ask Jan Key. Jan Key works 2 hats, one medical university and one with Charleston Medical Society. And I want to prompt her. I just want her to tell what the Charleston Medical Society did to help the nurses in the school district real quick.
You're muted, Jan.
How about now?
Good.
All right. Just a couple of weeks ago, I thought Zoom meant go really fast. And now I Zoom and I WebEx and all kinds of things. But anyway, the president of the Charleston County Medical Society attended our monthly meeting of the Charleston County Medical Society School Health Committee, which is an advisory committee that's been in place for about 50 years, and responded to a need for additional PPE for school nurses whenever the schools do reopen. And he pledged that the Charleston County Medical Society would give between 500 and 1,000 gowns to school nurses that they can use when they're taking care of sick students. Thank you, Paul.
Thank you.
Okay. The other thing I want to check, the MESC also, and I know I'm not just trying to say MESC because I know Roper's helping too, but y'all have put out a request for your nurses also I mean, not your nurses, but how the MUSC is going to be out trying to work in each school to help them with resources as well too.
Can you hear me, or am I?
Yeah.
Yes, okay. Well, what MUSC is doing is the School Health Committee made a request to MUSC reopening advice, what is it called? Back to Business. And there's another name for it too. Asked for advice about what to do as far as the logistics of the buildings and everything. Everything's changing day by day. So this was about 2 weeks ago. So MUSC Back to Business, Ed O'Brien, made a proposal to the school district to help as far as inspections and logistics of reopening. The other thing I'm doing as the doctor backup for the school nurses is trying to figure out a very detailed protocol for school nurses as far as how they will conduct business in the school nurse clinics at each school. And we're using DHEC recommendations, Department of Education recommendations, school district recommendations, as well as what protocols are used for nurses at MUSC.
Thank you.
All right. Well, thank you. Anybody else have anything here? Well, I want to say thank you to everybody. The city is very, very fortunate to have this group together. There's not a lot of cities that have this level of expertise that come together on a regular basis, and not just you, but the people you work with that have certainly been helping the city with health and wellness. And I can't tell you how much we appreciate you. So thank you very much. But if there's nothing else for this meeting, we'll stand adjourned. Thank you.
Thank you, everybody.